Thank you, Eric, and thank you, Ashley, for setting up the slideshow. I am excited to be here. I love Montreal, and I'm very excited and honored to be able to come and talk to you today about the economics of nutrition. This is what I do on a daily basis. And I'm going to be talking about cost effectiveness. We've talked a lot today about the behavioral economics, and I'm going to take it a little bit more on the how do we decide in a rational way where we put our resources. Disclosure, I am an employee and a shareholder of Abbott Nutrition. So when most people think about economics, they think that economics is about money. I think that's, economics. Oh, money. You could do my taxes, you can. Economics is not about money, and we need to think about it in a different way. Economics is about money in the same way that great painting is about paint, okay? Money is a useful tool to do economics, but economics at the end of the day is not about money. Well, what is it about then? Right? What is economics about if it's not about money? Economics is about resources. And resources can be anything. It could be land, it could be cars, it could be food, nutrition, healthcare, cell phones, technology, anything. Time. Time is a resource. And it's about how those resources are distributed to a population under conditions of scarcity. And that's what economics is. And so as I talk to you today about economics and about the economics of nutrition, and in particular nutrition in the healthcare setting, don't focus in on money. Think about what the money represents. The money represents resources that are going to a particular population for a particular reason. And when we talk about medical practice and healthcare, there's all kinds of things we could spend money on in healthcare. We could do lab research, ambulances, public health, diagnostic testing, vaccines, and nutrition. When you put these two together, health economics is about the distribution of healthcare resources under conditions of scarcity. So the question that we face is, how do we distribute our resources in the best way possible? The way that produces the most health, the most benefit for the population. And that's my job. That's what I do day to day. It's what I did at the Centers for Disease Control. It's what I do at Abbott. I try to figure out how we can best spend our time, our money, our resources on health. So, costs. There's lots of different costs that we could look at when we're considering health economics. There's direct medical costs. This is what you usually think of when you think of healthcare cost, right? So the cost of going to the doctor and getting treatment, the cost of getting a test, costs that go directly to the healthcare system. There's non-medical costs. So these are costs that are incurred in connection with a healthcare illness. So it could be transportation. It could be you need somebody to look after your children as you go to the hospital. Travel time. So things that aren't directly spent on healthcare, but are nevertheless associated with healthcare. There's productivity losses. So this might be things like you're missing work because you have a chronic illness and you're not able to work. Or presenteeism, where you're at work, but you're not as efficient or as effective as you could be, as you want to be at work, because there's some kind of illness involved. There's some deficit in health. Then there's also intangible costs. Not everything, not every cost is easy to see or to put a dollar value on. So there's pain, there's suffering, there's emotional loss, and there's social stigma. And these are all costs that we could think of when we consider different healthcare interventions. On the other side, we have benefits. So what are the benefits that we might see from a given healthcare intervention, like good nutrition? Well, we could talk about the negative medical outcomes that are averted, right? You could have a decrease in sepsis, pressure ulcers, decrease in death rates. Those are benefits of medical interventions. We could have positive medical outcome gained. So this could be your glucose could be better controlled. You could have improved gut function. And we could talk about improved quality of life. Health is not just the absence of disease, and it's not just the preservation of life. Health is about having high quality of life. It's about functionality. It's about being able to go out and do those things that you enjoy doing. It's about being able to get dressed, about being able to go to work, being able to go out dancing, and to take care of yourself. So these are potential benefits that we could consider when we talk about healthcare interventions. The way we talk and the way we think about healthcare benefits and costs really determines the type of health economics analysis that we are conducting. And so I'm going to go through a couple of the different types of different analyses that we can talk about when we do health economics. And this is all laying the framework to talk about nutrition, and particularly nutrition in the healthcare system. So first we could do a cost analysis. And cost analysis is fairly easy. We just look at cost, and we measure the cost in monetary terms. How much does it cost to have a specific intervention in a specific population? We're not even going to look at the benefit. We're going to say, well, to give everybody in the population this intervention, it will cost X many dollars. Okay? So a cost analysis. Moving down the line, we could do a cost-benefit analysis. When we do a cost-benefit analysis, the costs are measured in monetary terms. They're measured in dollars and cents. We also measure the benefits in dollars and cents. So we could say we have a particular intervention. It's going to cost this much money, but it's going to prevent this many people going to the hospital, which will save an offsetting amount of money, right? So this is typical cost-benefit analysis where we compare the benefits and costs in terms of monetary gains. Well, we can't always put a dollar value on the benefits of a healthcare intervention. There's something that's very hard to do in some cases. So we'll do something what's called a cost-effectiveness analysis. In this one, the cost of the intervention is still measured in dollar terms, but the outcome, the benefit, is measured in whatever outcome the intervention targets. So you can say it costs $500 to prevent one pressure ulcer, or it cost $800 to prevent one person from falling down the stairs for a specific intervention. So we could have a cost-effectiveness analysis. And then finally, we have a cost-utility analysis. Cost-utility analysis, again, cost is measured in monetary terms. The benefit is measured in terms of what we call a quality-adjusted life year. And a quality-adjusted life year, this is Health Economics 101. A quality-adjusted life year is a measure that accounts for both longevity, how long individuals are living, and also their quality of life. Okay? So the goal of an intervention, you could have an intervention that extends life but doesn't do anything to improve quality of life. Or you could have an intervention that doesn't extend life at all but makes the remaining years of life much better quality, improves quality of life. And this measure is a way to compare those interventions to each other, to decide which intervention is worth the investment. So to explain quality adjusted life years, there's this graph. On the vertical axis, you have the quality of life index. If somebody is perfectly healthy, they're perfectly capable, they can go out, they could do all the exercises, they could get themselves dressed, they could drive their own car, do everything they want, their quality of life is high. It's 1. So they're in great health. And as their quality of life decreases, as they get ill, as they lose functionality, their quality of life on that vertical axis decreases. So until 0 is when somebody they're dead. So everyone is between 0 and 1 by definition. And then you look at how long they spend in that healthcare state. And that's the horizontal axis time. So a couple examples, you could have a person who has a fairly high quality of life. They have quality of life index of 0.9. And if they live for 1 year, you would say that person gained 0.9 quality adjusted life years. Great. We have a next individual here. They start off fairly healthy, but right around February or May, their health declines, their quality of life worsens, and worsens quite a bit. They still finish the year, right? But that area under the curve, that pink area, is 0.7. So they have 0.7 quality adjusted life years. They live for 1 year, but when you adjust for the low quality of life, 0.7 quality adjusted life years. And finally, we have another individual who starts the year sick and unfortunately passes away right around August. So that person gains 0.4 quality adjusted life years. I know this is kind of a technical piece, but this is important background for what I'm going to share with you in just a little bit. And this is how economists are able to compare interventions that have very different outcomes. A cancer intervention and a diabetes intervention have very different outcomes that you'd want to look at. And this is how economists compare those on equal footing. So with that background in place, I want to talk to you about the NOURISH Cost-Effectiveness Study. And this is a study that is based on a randomized clinical trial that was published in 2016. It was published by Mick Dutz, who I noticed is on the agenda to speak on Saturday, so he's always a great person to hear. And he led this study. It's a multi-center, randomized, placebo-controlled, double-blind trial of an oral nutritional supplement, a high-protein oral nutritional supplement with HMB that was given to patients who were admitted to the hospital with either COPD, AMI, CHF, or pneumonia. And these patients, when they came to the hospital, they were screened using the subjective global assessment, and if they were now malnourished, they could participate in this study. And half of the patients then, or approximately half, received the high protein supplement, 328, and 324 received standard of care. They received 2 servings per day while they were in the hospital, and then they continued, per protocol, they were supposed to receive 2 servings per day for 90 days post-discharge. Okay. So this is a study that was published last year, and it is, to my knowledge, the largest randomized controlled trial of its kind that's taken place with a oral nutritional supplement. The primary outcome that they were looking for was readmission to the hospital after 90 days, or the composite event of readmission or death. And they didn't find a significant difference in readmission or death after 90 days. But they did find a difference in 90-day post-discharge mortality. In the treatment group, mortality was 4.8%, those who received the high-protein ONS. And in the control group, it was 9.7%. So, I'll be honest, nobody was really expecting this. We had hoped for it. But when we saw the results, that was very, very exciting to see that nutrition could have such an impact in this population, that it actually had an impact on mortality out to 90 days. So that's the clinical background of the study. And if you want to hear more about how the study was conducted, the other markers, I really encourage you to go look up the paper, because I'm not a clinician. You guys, everyone in this room knows more about nutrition science than I do. I'm an economist. And so my job was to come in and use the data from this study to say, okay, we know that this intervention had positive effects on mortality. Is it cost effective? Is it a cost effective intervention? And that's the question that I sent out to answer. How do we do that? Well, when you do a clinical study, You have all of this data. You know how long people were in the hospital. You know if they went back to the hospital. You know what they were in the hospital for. You know if they see a doctor outside of the hospital, what medications they're on. In this case, we asked them questions that let us know their quality of life score, right? How they were doing on that vertical axis. And of course, we knew survival. We knew how long the patients lived. So I was able to take that data on patient outcomes and outcomes of the study and marry it with data on the cost of the different interventions. So if a patient went to the hospital and they were readmitted for pneumonia, I was able to go to public health databases or publicly available databases and say, okay, the average cost for an admission for pneumonia is this many dollars. And I was able to go through that and do that for every patient in the study. And by combining these two sources of data, we are able to do a cost-effectiveness analysis. And I say I here, I should be clear, I worked on this very closely with my colleagues from Tufts University, Josh Cohen, Wendy Zong, and Peter Neumann. So what did we find? Well, for cost, the cost of the supplement, we estimated $3 per serving of the supplement. The supplement wasn't on the market yet, so what we did is we took a premium supplement on the market and we said, well, if this costs just a little bit more than the premium supplement, we're going to take that estimate. And so the $283 was based on the actual consumption, right, which was impacted by compliance in this population. So $283 was the cost of the supplement. Cost of hospitalization was very similar between the treatment and control group. It was only $154 more in the treatment group than the control group, and this was for the first hospitalization. Cost of readmission, again, very, very similar between the two groups, slightly higher in the control group than the treatment group. Then the cost of other medical care, so this would be rehabilitation, outpatient visits, again, very, very similar between groups, just slightly higher in the control group than it is in the treatment group. When you put all of this together, the difference in cost between the two groups is only $372. The treatment group costs $372 more than the control group, and of that, about 75%, $283, was the cost of the product, the high-protein oral nutritional supplement. So that's the cost. Remember our scales, that's one half of the scales. Now we're going to talk about the benefits. When we look at the difference in quality-adjusted life years for this 3-month period between the two groups, we find that the treatment group has more quality-adjusted life years. Now remember, this is a combination of how healthy somebody is and how long they live. So this is being driven both by their functionality in the 3 months of the trial and their probability of surviving to the end of the trial. The difference in cost, $372, and you divide that by the difference in quality-adjusted life years, so 372 divided by 0.011, you get $33,818 per quality-adjusted life year. Now, I know that unless you're a health economist and you do this stuff day in, day out, that number doesn't mean much to you, $33,818. I'm going to put it in context in just a little bit by comparing it to other well-known interventions. But just for now, understand that anything below $50,000 per quality-adjusted life year is considered to be a cost-effective intervention. Okay. Well, that was for a 3-month period. But if you took the oral nutritional supplement and had a higher probability of survival, then really the fact that you took that oral nutritional supplement gives you benefits for the rest of your life. You didn't die in that 3-month period immediately after a hospitalization. And so we needed to model out the benefits and the difference in benefits for the rest of the life of these individuals. And we did this using life tables that we were able to control for age, sex, race, comorbidities, including the comorbidities that they were in the hospital for. And we went through everybody in the sample again. So that gentleman on top, he was in our study. We followed him through the 3 months at the end of the study. And based on his age, sex, race, and comorbidities, and using this life table, we estimated he lived for another 9 years. The gentleman in the middle there, he was in our study, and he passed away after 2 months. We don't need to make an estimate for him. We know what his life expectancy was. It's 2 months. The gentleman at the bottom there, he's not quite as healthy as the gentleman at the top. He makes it through the 3 months at the end of the study, but based on his age, sex, race, and comorbidities, his average life expectancy is 7 years. Okay, so we went through everybody in the study and did this, and modeled out their expected survival, their expected life expectancy. In the treatment group, it's 8.77 years. And in the control group, it's 8.06 years. Everybody in our study was over age 65. A lot of them were much older. So this is not a surprising life expectancy. But the fact that if you took the treatment, if you were in the treatment group, you had on average 0.71 years of increased life expectancy, about 8.5 months more life expectancy, because you're taking this high-protein oral nutritional supplement. And again, this difference between the two groups is driven by the fact that those in the treatment group were more likely to survive to 90 days. So when we do this analysis, we take the cost difference. It's the same cost difference, 372. We divide it by the change in life years, and it costs $524 for an additional life year to implement this intervention. $524 for an additional year of life. Now, because we're health economists, we want to say, okay, they live for another year, they're older, they already are malnourished and they have illness, their quality of life is probably not 100%. Let's adjust it and we'll say their quality of life for remaining life years is 60%, 0.6, okay? So that would be $873 per quality adjusted life year. This includes treatment costs, hospitalization, readmission, medications, everything else. Well, $873 is an extremely cost-effective intervention. To give you some context now, I told you before, anything below $50,000, just as a back-of-the-envelope estimation, is considered to be cost-effective. Aspirin to prevent cardiovascular disease in women with moderate risk, an extremely cost-effective intervention, well known, $16,000 per quality adjusted life year. Influenza vaccinations in the US for the population over 50, $8,000 per quality adjusted life year. Daily versus alternate day dialysis for kidney injury, $5,600. Warfarin for AFib in 70-year-olds, about $2,500. This intervention, the NOURISH high-protein oral nutritional supplements, and in elderly population admitted with cardiopulmonary disease, malnourished population, $873 per quality adjusted life year. Now, what excites me about this? This is the story I tell people when I go over this. This is what I find exciting. This takes the idea of nutrition in the hospital from being one of those housekeeping costs that you just have to do because people are staying there, like having clean bed sheets. It takes nutrition from that and makes it into one of those extremely low-cost, low-risk interventions that has the possibility to save lives. And it has the potential to change the way that physicians and healthcare professionals think about nutrition, both in the hospital setting and in the post-discharge setting. So, very excited about this result and this study. And that's in a nutshell, how we look at cost-effectiveness analysis when we talk about nutrition in healthcare. Cost differences were very small. There is a clinically significant difference, an extra 8.5 months of life years gained. Highly favorable cost effectiveness, $524 per life year or $873 per quality adjusted life year. Thank you very much.
Thank you, Scott. Time for questions. Leah.
Thanks, Scott. Nice presentation.
Thank you.
How do we use this information to nudge healthcare systems? Is this an example where education, information needs to be applied at a clinical and at a system and policy level? How do you move the next step? Because you're right, no one's ever shown the impact of nutrition intervention on hospitalized patients, and the news we get from critical care is all, it makes no difference, and yet the nutritionists in the crowd who take care of patients know that it really matters. Just as a point in our Canadian Malnutrition Task Force study, 1,000 Canadian patients supported by CNS and Abbott, half of them had SGA-B or C, so similar patient population. 1 in 5 were on oral nutrition supplements when they hit the door. None of them got their oral nutrition supplements, so they had their treatment stopped. They came in on treatment and it stopped, and it probably contributed to morbidity. So the question is, how do you turn this into a nudge at the level of healthcare systems and clinicians?
So I think I am a big fan of having strong protocols in hospitals. And I think that it's research like this that helps you get strong protocols into hospitals that say, we're going to use a validated screening tool on every patient who comes in the door. And if they are at risk of malnutrition, we're going to have automated systems in place so that they get oral nutritional supplements or whatever therapy is needed in a timely fashion. Now, we can do that in a number of ways. We could have it integrated into the EHR. But I'm a big fan of using hospital protocols to do that. And then as far as outpatient, we're still working on it. I mean, I wish there was a magic pill. I think that there are protocols that we could put in place for outpatient and discharge instructions as well that we could do that will help patients in the outpatient remember to keep their, but I think the first step is this research, and then communicating it and helping people, and in particular hospital administrators, realize that nutrition is not the same as having clean bed sheets or washing windows. It's a therapy that people need to maintain their health. Yeah.
I'll just add to Leah's remark that through CMTF we've made, we did nudge. We made change from the earlier years, but at the same time you have ministers who are knowledgeable about the research, the results of our research, but at the same time who are cutting the food budget in hospital. So there's a nudge at that level that still has not sinked in, because probably they are compete, interests compete in terms of whether it's cost of medication or other issues.
Yeah.
So.
Ashley. What?
Just one quick follow-up question to both earlier comments. In the face of such overwhelming data of cost benefit, why is it that it still hasn't leaped ahead to past that, say aspirin and everything else?
So I think a couple things. I think this data is new, right? This was published last year. It is in the public domain now, but it's new. I think that's probably part of it, and I think it's changing the way people think about nutrition. Aspirin is, they think, oh, it's a drug. And if you had a drug that can do what nutrition would do, it would be a blockbuster, right? Everyone would be excited. But people have this mentality, I think, that nutrition is somehow just not on the same level. And I think we fight against that by producing this and showing it and presenting it. Yeah.
Mary Labbe, UT. A question in your cost. How do you figure in the cost of screening? I mean, do you do like a screening protocol and only like for risk and then do screening afterwards? Like, how was it built into your costs? And then how do you see that screening being sort of operationalized?
So in this particular study, because it was a randomized clinical trial, the screening wasn't built into the cost, because we actually had to screen a lot of patients who didn't qualify for the study. So yeah, no, that's a very good point. Screening was not put into the cost here. We do have other research that has been published with Advocate Healthcare Center in Chicago and some others, where they have implemented new screening programs, and they have calculated the cost of the additional man hours for having screening programs and having it in there. But yes, that wasn't part of this. Yeah.
So I guess one of the questions was, why hasn't this been implemented? And you were reporting on one study, and obviously it's hard to put a lot of faith in one study, and what we're really looking for is multiple studies. So you didn't talk about the uncertainty, but I'm sure at some point in this you did acknowledge it.
Yes, yeah. No, there is an uncertainty, and we did some modeling of uncertainty, but I mean, to be totally transparent, it's a slam dunk. I mean, 873, you could have a lot of uncertainty, and still it's very much worthwhile. You could always say we need more evidence, and I was having this discussion with you last night. This isn't like a drug where there's potentially really harmful side effects, right? Where you probably need 3 well-conducted RCTs and have to go through a review process, et cetera. This is high protein with HMB. And so the level of evidence is probably never going to be at the level of a pharmaceutical drug. It's just the funding's not there. They'd have to charge hundreds of dollars for a bottle to get that kind of level of evidence. So I think we have to work with the evidence we have and make sure that people are aware of it, and where we can, pick up new evidence. Yeah.
Okay, I've got one question for you, and it's sort of on a macro level. I'm going to guess it can't be answered.
Okay.
But many people in this room have been involved at some level with federal dietary guidelines. And we know that the compliance is low. But we do it, and we do it a lot. We put a lot of time and effort. Is the data there to do a cost-benefit or benefit analysis on dietary guidance? And what do you think might happen if you did it? That easy question.
So short answer, I don't know. I think it'd be an interesting thing to look at. So, short answer is I don't know. Sorry.
Thank you, David.